You're listening to Charting the Future, a podcast for independent pediatricians by PCC. For more information about our software and services, please visit www.pcc.com or visit us on social media.
Welcome back, everyone, to Charting the Future from PCC. I'm still your host, Hart, for as long as they let me. I am going to be doing something different today. Instead of interviewing a pediatrician or someone who works in a single pediatric office, I've brought for you what we call internally at PCC a SME, a subject matter expert from PCC. I've got Morgan, that you all know her as Morgan, but Morgan Ellixson-Boyea is the operational head of our clinical data exchange group at PCC. I even kind of screwed that up. This is like my third take, so forgive me, guys. We just know each other using internal PCC language, and when you actually try to explain it to someone else, it's a little funny. I brought her here today because we find that a lot of things that PCC works on behind the scenes are going to be very, very interesting to you as pediatricians and you who work in pediatric practices that you might not be aware of. And a lot of the work that we do, as you know, ends up in public. Like we publish data, or we share what we've learned about something, or we even have opportunities from time to time to influence things that happen in the market. And Morgan's one of those people at PCC who has expertise in an area that everyone except for her and the people on her team have insight into. Because they're out over in this corner. We just call the e-prescribing people. So I thought I would bring her here today to give you a view into a space that you normally don't get to see. So welcome, Morgan. How are you?
Good, Chip. Thank you for having me. This is an honor.
Well,
honestly.
It's not an honor, but I appreciate you coming here. All right. So I do have a question for you to open.
Yeah.
It's the same question I've been asking everyone. I don't actually know the answer to this question myself in this instance, but do you remember where and when we first met?
Man, good one. Okay. So I started at PCC in 2014. So it must have been around there, right? I came over from the hospital and started here full time. You were kind of like a celebrity, and you still are, but you're one of these people that, you don't just walk up to and start, like, hey, I'm Morgan, pay attention to me, I'll tell you, probably the first time I remember that we sort of like connected, and maybe when you realized that I was cool was, I like to think you think I'm cool. The San Francisco UC, the users conference in 2015, I got invited to go to the Beer Geek after party. And that's what I like to think is the first time that you and I were like,
I do actually remember that very much. Our friend Narain Shenoy was there.
Oh, yeah.
You don't want to say rest in peace because he's still alive. He just doesn't practicing anymore. And we had a whole lineup. Yes, I do. I actually do remember.
I remember that. So that was within the first year. So I'll count that. And, many other delicious beverages we've shared, over the years.
Over the years. Cool. That's pretty good. I will say this. When new people come to PCC and they get shown around through the office, for the last 20 years at least, I have literally been in my office and seen them walk right by me and they introduce everyone else down the road and they skip me. So I sometimes don't get to meet new PCCers for 6 months or a year. And I don't know, you don't know who these kids are. So why don't we start by telling our audience what it is that you do for us? And then
the team that I oversee does clinical data exchange. And so we're the team that the majority of what we work on is third-party interfaces. So you connect with our EHR, and then there's all these other entities out there in the world, like your immunization forecasting and immunization registries and your lab vendors. And then the part that is near and dear to my heart is the prescribing software. So there's a whole long story about how we got there with the prescribing software, but the majority of it lives here at PCC. But no prescribing software is complete without SureScripts. And SureScripts is the entity in between EHRs and pharmacies. So we still have some third-party connections, which is why what I do, remains on that team. So my long experience with living in the pharmacy world kind of brought me here, and I can tell you all about that too. But
I want to hear about it.
Yeah, we'll get into that too. But between myself and Dewey Howell, who's a family medicine physician, we help make this prescribing software work. And the prescriptions that you write every day go zip off to the pharmacy, and just, kind of try to keep an eye on what's going out there in the industry, what the problems are. There's all sorts of things that we could say about that. But yeah, mainly keeping an eye on the team that takes care of all those cool interfaces and making sure the prescriptions are happy.
Well, I'm pretty sure that we have the only pediatric EHR tool on the market,
Yeah.
which is funny. We don't talk about it, and we're not going to go into it at great length here, but it does mean every now and then Morgan gets to show up at the users conference or, at a release mid-year and does something that all the pediatricians just, their mouths fall open. Like, oh my God, you can do that now?
Yeah.
And to us, it's like someone's birthday. We are going to circle all the way back. But what I want to hear first is, how did you end up at PCC, especially coming through your pharmacy background?
Yeah.
After following the Grateful Dead for 10 years, Fish, all right, then you decided.
Yeah. I was wondering if we'd get into that and be like, well, I was just on Fish tour and then my van broke down. There's lot of stories we could tell. You might be able to tell, but I'm from Central New York. I figured Chip would make fun of my accent at some point.
It hasn't come out yet. It
hasn't come out yet. I do sound like I'm from Minnesota sometimes, but it is Central New York. I chose to go to school at Clarkson, which is way up at the very tippy top of New York State. I was doing like biomolecular science, engineering, that kind of stuff. And after that, I ended up in some labs. I was doing microbiology. For a long time, I worked at a yogurt plant. And I got plenty to say about yogurt. That could be a whole other podcast. I'm lactose intolerant. I shouldn't have done it in the first place. But labs are really cool. I love science. I love all of that. But nobody comes to visit you in the lab unless they want results. They come, They want the lab results, and they take off. So I had enough of that. Drugs were always fascinating to me. Pharmacology and pharmacotherapy, like all this stuff. And I thought, maybe that's what I should start doing. And I headed over and began working at Walgreens. So I worked in outpatient community pharmacy for a while, a little tiny hospital in upstate New York, like 100 beds. I was doing that. And then the big city of Burlington was calling my name, mostly nectars, right? Because of Fish. And so I, just packed it up. I used to work here at the Trauma One Center that we have. It's like 700-800 beds. It's a big university hospital. And I love pharmacy. I really do. This was inpatient pharmacy. So we're taking care of the patients that are admitted, and that could be anywhere from like oncology, the OR, it's research pharmacy. It's a really big department that we have. But that stuff weighs on you just like it does, with our doctors. It's 24 hours a day. It doesn't stop. And the patients are huge differences in like how sick that they can be and stuff. I knew it wasn't for me long term. You're getting burned out. And do you remember Craig that used to work here? Craig and I worked together at the pharmacy, and he said, you know what? We could use somebody like you to come over. And so I did it. We came over and we did a desk job, which was new, for me. There's no lab coats and, all that kind of stuff. But eventually, then our e-prescribing product grew, and it just became this natural transition that I moved over there and started, taking care of the prescription.
I remember, because you were essentially champing at the bit the whole time.
I was
Hello,
ready.
I'm going to be working on that. I know I've got this job over here, but you're not going to stop me from working on this, especially because none of you all know anything about it, and this is what I do. I remember those days.
That was all with love, but I was like, guys, I'm ready to help. If anybody wants, I actually know what this stuff is all about. So in hindsight, it was an incredible, transition. I still worked per diem at the hospital, for a while, just to keep things fresh. I just loved it. It was a different part of my brain. But then we adopted that Siberian Husky I've got, and I can't be out of the house for a 12-hour shift, so I'm home more often now.
I do remember the first eRx product we used, and we're not going to name them, right? But they were the first eRx product we used, and they flew out before we sort of constructed our own. Yeah. They came out, and you were in the room. They had a room full of PCCers to give us instructions about how their eRx tool would work. And we were all sitting there knowing how our clients operate. And I remember on more than one occasion, they would show us a screen and we'd be like this. And someone from PCC would say, well, what happens when you hit that button right there? And they'd say, well, don't hit that button. We'd say, well, we're not going to hit that button, but our clients are going to.
Absolutely.
And then we were like, so why is that button on the screen if you're not supposed to hit it, if it's going to delete everything? Well, it's just the way we've designed it. Or then I remember another time it took them 20 minutes to explain to us why. I'm going to get it wrong, but it was like, why hitting the button that says save deletes and doesn't save? If you want to save it, you have to hit the delete button. But if you want to delete it, you have to hit the save button. And we're like, why did you design it that way? Why don't you just flip those things around or rename? And they were like, well, that's just the way it is. And that was my introduction to e-prescribing software. But fortunately, we don't have those problems anymore.
No, remember, we used to call it Faceplant Friday because the software would just stop working every Friday. And someone would come interrupt a meeting and open the door and they'd say, Morgan, and I said, there was nothing I could do except file the complaint. But pediatricians need to be able to write prescriptions every day and consistently, and having that drop all the time was like, it just wasn't going to work. And so that's eventually when we met up with Dewey and his team, which was far better experience than we ever had with who.
We now have a bespoke solution, and I think it's easy to take for granted. I want to ask you, what are you doing that you're excited to share with people?
Well, I can tell you what I'm excited about. One of the things that I hadn't realized, because I started wondering about the medication landscape for pediatrics. Like, it's pretty... They only prescribe about 30 to 50 drugs. Like, there really isn't this like wide expanse of things. And that's good. They know what works and it takes care of the kids. And some of the patients that really need extensive, more specialized care are seen elsewhere. So we don't see those prescriptions. You see them at the hospital, but not with our offices. But I think the first time in like 30 years, there's a new antibiotic class that they discovered. They found it in soil, I think. I forgot to write down the name, but it hasn't gone to market yet, but I think we've got something coming which should help for all of this like antibiotic resistance that we see, because our pediatricians are really good about not overprescribing this stuff, but that's our pediatricians. It's not the ones at the emergency room or these minute clinics and stuff like that, where we're creating stronger bugs every day and we haven't come up with anything new to do anything about it. So that was cool. Some of the things I'm seeing that I'm excited about are we're making changes to our real-time pricing benefit service to make some changes with that, which is very PCC specific, but it'll make sense to, I think, multiple users. And then we're bringing in the concept of being able to process an electronic prior authorization from inside the EHR. So we can talk a little bit about that too if you want. I don't know if there's anywhere you want me to start.
No, start at the real-time pricing.
Yeah. What I want to tell you about before we get to pricing is some stories about the inventory problems, because I think they all kind of lead into.
I think I know where you're going with this. Yeah.
I wasn't sure where.
Does anyone here have a friend or a kid who needs ADD medicine? What was the Al Pacino movie Needle Park from the 70s, where it's a whole movie about a heroin addict chasing heroin all over New York City. And I'm like, I can't believe there isn't a movie yet about teenage kids and adults chasing Ritalin all around town.
No, it's very realistic what I'm about to discuss, but they all do line up together. So the inventory problems, figuring out where the heck they even have these drugs, then using our software to figure out if it's covered, and there's some trouble there. And that's what I'm excited to see, the improvements there. And then if you do really need a prior authorization, we're going to be able to help with that. So I think that's start at the beginning. Imagine that you are a doctor or a nurse at a practice, or you're a dad. So in this scenario, you could also be the dad, or you could be like an 18, 19-year-old kid, and you need a prescription for Adderall XR30. And you're like, I don't know who has this, but I'm going to call my pharmacist. So pretend you're calling me. I'm going to answer the phone.
Hello, is this Hannaford's Pharmacy on North Avenue?
Hi, this is Morgan at Hannaford's. How can I help you?
My doctor wrote a script or just gave me another 30 days of my Adderall. I can't believe you're having me role play. I have 30 days of your Adderall, and I'm wondering if you have it, because I've called 3 other pharmacies today and nobody has it.
Man, what a bummer. What strength is it?
Well, obviously it's adult strength. I don't know.
XR30. We'll say
XR30.
Adderall XR30. Have you been to our pharmacy before?
No, I live in South Burlington, not Burlington.
Oh, okay. Goodbye. Click. That
Yes.
could happen. That's the first part. See you later, guy. Because I don't know, you might be a bad guy.
You might be you might be selling your drugs all over town.
Yeah, I got stories for days. So, let's pretend you don't have to pick up the phone again, but just pretend that I didn't hang up on you. You said Adderall XR30, and maybe Hannaford or whatever pharmacy chain, they don't want me to tell you that I've got it in stock.
That is the story I've heard a lot. They're like, we can't tell you, you got to come in.
You got to come in. So I've worked with pharmacists that have been robbed at gunpoint for drugs. And so I can see where people might, even if the big company says it's fine, you might say, man, I'm good. I'm not telling this chip Hart, what I've got in stock. But maybe I'm nice and we're pals. And I say, yeah, I got some, come through. So you hang up the phone, but you're hungry. So you go to lunch, maybe you have a beer, you run some errands, and then you drive up to the drive-thru at the pharmacy. It's a 12-hour shift, so I'm still here. And you say, hey, I talked to you earlier. You said you had Adderall XR30.
Yeah, you snooze, you lose.
You snooze and you lose. That's the first problem. So you didn't show up fast enough. Somebody else came in. But maybe you slide that paper prescription towards me, and I look at it, and I say, oh, dude, you told me Adderall XR30, but this is actually the generic. That's not what you asked me for. So I didn't even have all the data to tell you yes or no. So I say, well, I did have brand name Adderall XR30 2 hours ago. I don't have the generic. Nobody does. And then I just send you on your way. So that's real. And this is happening like every day. You send the kids there. So maybe Walgreens doesn't have it and you drive over to CVS. They don't have it. Oh, but you went over, Walmart does have it. Well, Walgreens has your prescription. So how is that supposed to get over here? You can't just do that. So there's one thing that PCC can't solve, but I'll tell you the cool thing that we built, and that's a button inside the EHR called resend. Because I kept saying to Dewey, and Dewey knows this too, he was a doctor, and I said, God, I just wish there was a button that you could send the prescription from pharmacy A to pharmacy B. And he says, well, we can't do that, but I can build you something that'll feel like that. And so he went to work, as he does behind the scenes, and created a button that I have to go back to the chart, find that Adderall prescription, and I click resend, and it cancels the first prescription and sends a fresh one over to, pharmacy number 3 or 14 or whatever that has it. So that's been a huge win for these type of medications, where before they'd have to cancel it, search for the drug, fill the whole thing out, change the pharmacy, and send it. So if you like counting clicks, which we do, it was saving you like 8 or 10 clicks to be able to send that. That came out a couple of years ago. That's awesome. I don't know anybody else that has that. I don't go snooping on other EHRs, but I think we might be one of the only ones that has that. Then you might say, why isn't there just a repository of what everybody's got for inventory? Well, that would be nice, but it does not exist. So it's not something that we haven't connected to yet or that we haven't built. I don't know if they ever will have that kind of information in a centralized place, because what if we are bad guys and we find out that the pharmacy down the road's got 20 bottles and you and I go get face masks? I don't know. It's
I think there's the pharmacies, as you know, are hyper competitive, and there is real competitive intelligence in knowing what your competitor's inventory is at any given moment. And I don't know if anyone listening to this is familiar with the big Epic lawsuit that's out right now against what are they called, Health Gorilla or Gorilla? What I think it's Health Gorilla. Yeah, the first shoe dropped on it. To make a long story short, all of the EHRs, most of the EHRs to some extent, have clinical data exchange at a very high level. We work with something called Care Quality. It's what allows you to send and receive your charts to an Epic-based hospital. But the vetting that went into all of the vendors who joined this network was really minimal. And furthermore, a number of vendors would join the network and then allow subcontractors to use their clinical data exchange feed. And they literally last week, one of the one of the businesses in question admitted in court that they were grabbing patient records to sell and share with attorneys.
It's crazy.
And it's crazy. So all of that stuff makes PCC people freak out.
Oh,
And so
yeah.
we like privacy. We're big
Oh, yeah.
privacy.
We're very paranoid, and I think with good reason. I mean, it didn't happen within. This is a story I didn't think I was going to tell you, but you probably remember this. It didn't happen within our system, but it was a provider using our software that we found out about it this way. But one of our pediatricians, his identity was stolen, like legit, to the point that they had created prescribing accounts for controlled substances in another EHR vendor. And they would send a couple test prescriptions. You test the waters. You have to see if you can get, you
Like $1 Apple charge or whatever. Yeah.
Yeah. So they send through like a promethazine with codeine prescription, thinking like, oh, no big deal. It's a little cough medicine. No one's going to notice. False. The pharmacists pick up on this stuff because, like, why is this pediatrician in California prescribing for a patient in Georgia who's 56? Like, there's all these things that the bad guys aren't really thinking through. It's one of the reasons why I'm happy we have the ID proofing that we do, because we're really sure that you are who you say we are, and we're not helping some bad actor get in and start writing, those type of prescriptions. So this is real stuff, that happens.
Yeah, absolutely. All right. So you described how we bump into the inventory part.
Oh, yeah. Yeah. Okay.
That was the first step of your
the first step of the journey. Okay. So let's say maybe we know one of these drugs is in stock and we feel great about it. It's the perfect drug for this patient. And I start typing it up in our software. And at the point I'm prescribing it, we have a service through SureScripts on behalf of the pharmacy benefit managers, the PBMs, that sends information back and says if it is or isn't covered. And so the PBMs get to decide how all this works. And you and I probably, and all of our providers probably have lots of feelings about this, but the service that we offer is really nice, where this information comes back in and says, hey, it's going to be a $25 copay, or it's free, something like that. That's a nice one. It might say a prior authorization is needed. And that might give you pause as a provider. And you might say, there's something else that's similar that would work. But what if it says there's no prior auth required? You're feeling good. You write that prescription, you send it off to the pharmacy, and the family goes to try to pick it up at CVS or whatever. And at that point, CVS runs the prescription against the insurance and they say, whoa, man, hold on. This needs a prior auth. And so then you're thinking, am I crazy? Like I entered this prescription in my EHR, but the pharmacy says something different. So we learned something very interesting in the last couple months. The information that we receive at times in that call back from SureScripts and the PBM is more of like a probability than an actual adjudication. And so I don't want to get in trouble and get, the PBMs coming after me, but what I'm hearing is that it doesn't make sense for the PBMs to give you an actual adjudication for these earlier transactions because the patient's not in the pharmacy. They're not going to get paid for using the EHR. They get paid when the patient goes into the pharmacy. Because no matter what, you're probably going to buy something. At least I do. They got me. I'm already there. So there's a different, more thorough adjudication that happens at the pharmacy. And I can, I did this for a long time. So when Dewey realizes this, he says, this isn't going to work. And so that's what our clients are experiencing right now. Dewey's doing his data science master's on top of all of his other degrees at Notre Dame. And he is going to town on solving this. And so he's used a lot of his data science background and wrote this machine learning model that says, hey, when SureScripts and the PBMs tell me no prior auth is needed, he's like, I'm not taking that for an answer. And he's written this model that is going to look out to all of the PCC clients and say, all right, this kid's 12 and he uses Blue Cross and for this med, and there's all the other times this has needed a prior auth. And he's going to rate it, based on all these different levels of logic and says, there's an 80% chance this kid's going to need a PA. So instead of the no, we're going to say, get rid of that. And we're going to say, instead, here's like high, low, and and medium that you might need actually a prior authorization. So with all that, Dewey will explain this much better. I'd love for you to have him, on the show. You guys can nerd out. But if you're following this, that in that medium class, when you find out, hey, it's kind of likely you're going to need this, you might think, well, this is the only med that's going to work for my patient, so I don't care. I'm going to power through this and get the PA, or you might switch something else that's, in the
Then
same class.
you get to set the expectations for a
Mm-hmm.
mom who's harried, and you can
Yeah.
say, look, there's an 80% chance this is going to need a PA or it's going to need a copay.
Yep.
But I won't know until you get there.
Yeah.
And you can even say, I'm projecting, you and I did not coordinate ahead of time, so you can tell me I'm wrong. But you can also say, if you get to the pharmacy and it turns out that it needs a PA or the copay or whatever that they want you to pay is too big, pick up the phone and call my office,
Mhm.
and I will send them another script for
Yes.
something else 2 seconds later.
Yep.
And
Exactly.
it is annoying for the doctor, but it is so much less annoying than finding out that the patient didn't pick it up or getting the message much later and the mom is mad that you wrote this. It's the kind of service that our clients love to provide.
Yeah.
So
Yeah. I'm
and
stoked
the
about
PBMs though.
I know. So that change, that'll be coming out this summer. We're just finalizing that. And Dewey's got so many just impressive numbers showing what the impact is going to be for our users on this.
Yep.
And this is another one of those things I think we might be the first ones that are doing something like this. So I'm happy to brag about it.
No,
it's a really cool
that's
thing.
amazing. That's absolutely amazing. I would, in all sincerity, when PCC does something that other vendors don't, my hope is that we trigger them to do it, because everything that happens lowers the friction in the independent pediatric space, and frankly for other specialties as well. We have too many of our clients are dealing with high burnout. Too many of our clients are not feeling the reward of their work, and if we can just make their lives easier and make it more rewarding to work in their practices, they're strong enough to fight the anti-vaccinators or whatever the case may be. That's my mission these
Oh,
days.
I
And so
know.
I think it's great. I hope someone copies and steals it from us.
Yeah.
They won't.
that's-
They won't. Yeah. All
So
right.
if you think about all of this story, they've got it in stock now. That's great. The EHR is telling you better predictive information about, whether or not it's going to need a PA. Let's say it does need a PA. This exists today. This exists for all offices, all pharmacies. This is not a PCC specific problem. It's time to do that prior authorization, and everybody groans. The providers do, the pharmacy staff does, the patients do. They can't get their medications. The insurance company, though, is like, oh, yes, perfect. Do the dance, because they know the more dance you have to do, you might give up and pick something that will cost them less money. Right now, there's no way to process the prior authorization through our software. So they have to do everything manually. And maybe you're at the pharmacy, you found out, so you called the doctor and said, I got bad news. It's time for the prior auth, or the pharmacy calls. They have to go to websites and print out paperwork and get a pen, fill stuff out. You're dragging information out of the EHR. You have to use a fax machine, Chip. You got to fax this stuff crazy. There's a third party. There's a couple of third parties. There's one that's pretty popular called Cover My Meds, and almost everybody uses that. So you might go to Cover My Meds and you can process that, but you're not doing it in the EHR. And start to finish, this could be a couple of days, could be weeks. You might give up. You might, like anyone in the, that whole trajectory might give up. So it's not great for continuity of care for these patients at all. The project that we're working on, once we wrap up this new pricing change that we're making, is to bring the prior authorization process all the way in the EHR. So before they even get to the pharmacy, they're going to see it needs a prior auth, and you're going to press a button and kick it off. And this will go grab data from the chart, so you don't have to search for it. It will say, I tried all these drugs and failed, and this is why we want to do this. Information from their documents. You could upload anything that you need for the subsequent, paperwork. Send it out. No faxes. No external websites. And maybe if the PBM is playing nice and you have everything you need, you could be done the same day. So just imagine a world where the pharmacy's got it in stock. You get better advice, and you could process the prior authorization right at your desk. The doctors don't have to do it, and the providers. It could be the nurses. They're huge in this, and the referral staff.
Yeah, you guys for eRx, you need to get that Hollywood guy who does the voiceover. So it goes, imagine a world where one of the questions that I ask people is, what advice would you give yourself 20 years ago, knowing what you know now about
Mhm.
your career or medicine or even personally, what advice would you give yourself 20 years ago? And the reason I mention this is I joked when I was when I think it was in the last podcast I did when I was working with our friends from Practice Well. I said my advice 20 years ago would be to start a group purchasing organization for immunizations because
Mm.
I could buy a boat, like and and with you, Morgan, I'd be like 20 years ago, you and I should have started a PBM,
I
right?
I
It's
actually made that joke earlier today. I was like, to be an executive in one of these things and just gets to decide what is and isn't covered on the
yeah.
formulary. I don't know where they get this information from. They have to be smart people, but it's just so money.
I'm gonna
Yeah.
come back. I'm gonna come back and tell you where I think they get it in a moment.
Yeah.
What advice would you give yourself 20 years ago?
Oh man. That's interesting. I probably would have worked less. I would have told myself not, because I used to do doubles
Yeah.
at the hospital. It was all
Yep.
about money, and you just
Yep.
felt such a strong sense of helping. Like you were like, oh, if someone calls out, right? So you fill in for that shift because you're like, you don't want the patients to get sick, but can't let yourself get there either. And so I think
Yep.
maybe I would have left that type of pharmacy job earlier if I knew the kind of world I could get into, so maybe don't work so hard. I don't
All right.
know. That's a great question that I hadn't thought about.
Um, I will tell you. Let me tell you where I think they get their money. Where they get their money
Oh, I'd
from,
love to.
because they
Yeah.
get they get paid in their way. They get paid by the companies for whom they work. Like you're
Mm,
trying to drive this money down. So, um, someone I know, I'm keeping identity secret only because I don't have permission to identify him. But someone I know does data analysis for a large insurance company, who, among other things, they do Medicare. So they're one of the
mm,
private Medicare companies. And one of his assignments was to take a huge pile of claims for, I don't know what the data sample was, but like, let's say 1,000 patients. And these 1,000 patients had some pretty substantial healthcare costs. And his assignment was to look through all of the claims and look at their diagnosis history and the complexity of these patients and answer this question. Is it better off for the company to pay these claims and get credit with Medicare for the added complexity of these diagnoses, which means they get more money on the back end from Medicare to pay these claims? So is it better to pay $1,000 worth of claims and get $1,100 worth of money from Medicare? Or was it better just to not pay those claims and not get the complexity credit? And I pointed out to him, I said, it's interesting that there
yeah.
wasn't a third option, which was to pay those claims and not make as much money, because that's what insurance is for.
Oh, what
And
a packet.
yeah, and so I understand why they asked the question. They have to understand that because they're balancing, this is risk management stuff. And so
Mhm.
I suspect those PBMs are playing a statistical game that says if we push here, then we get more money there. And
Yep.
that means they've gotten more savings for their overlords, so they get a bigger piece of that. Anyway, that's my guess.
I know. What a
All
world.
right. What a world. So, all right, here's my other question. You effectively answered one of the questions I ask everyone, which is what are you looking forward to? So you just told me what you're looking forward to. What's keeping you up at night right now? What are you worried about?
Oh, the government. Am I allowed to say that? I
Yeah,
mean,
it's
man,
absolutely.
I just don't know how these people got to be in charge and they're making these kind of claims. And I'm worried they're coming for prescriptions next,
Right.
and the rules about prescriptions. Like, what if they just do away with all of the regulations that are there to keep people safe? And I
Mhm.
don't know. That's good. And the fact that no one's got these drugs. That one really too. I think about that. You should see these websites. Like and they're not like some homegrown website somebody, wrote up. These are documented websites that say this manufacturer refuses to say why we don't have this drug. I mean, it's just,
Right.
it's insane what's going on. So yeah, no drugs in the government, man. I always say the government.
Yeah, you say that no matter what the topic. What's your big fear in the arts and crafts world, Morgan? The government.
Oh man. Not enough free time, man.
Not enough free time. So one thing we haven't discussed, Maureen, give everyone a brief overview of what you do when you're not working at PCC.
Wow.
What's your side hustle? I mean, you have a couple, but like,
I do have
what's
a
your
couple.
like? Yeah.
Yeah. So I was working at the hospital, a couple of weekends a month, that kind of thing. I'm not doing that right now. I have an art studio downtown in downtown Burlington. I don't get there as much as I want because of the aforementioned Siberian Husky, who's like a toddler, basically. I do screen printing, tie-dyeing, I do some sewing, a little bit of knitting. I'm not so good at that. I was doing like resin art for a little while.
What is resin art?
So it's it's like epoxy, the two different types of epoxy that you mix together, and then you have like that base layer of resin, but also alcohol inks, and you put them in. They have different molecular weights, which the science comes back, but they you can move them around and kind of make like little rainbows. You could do magnets or.
I've not seen that work from you.
That one's cool. I could show you that. I used to do pottery back in the day, and one of our coworkers got me into a volunteer pottery class right now. So we're making bowls for the Empty Bowls event. So I'm whipping up bowls, not very well because I'm a little rusty, but I'm getting back to the pottery wheel. So I love that kind of stuff. Camping.
I don't know why for a couple weeks Instagram was feeding me all of these pottery fail shorts, and it was like women getting their hair caught in the wheel and stuff like that, and I couldn't stop watching them. I think that's why I keep getting it to me. But who are all these people who video everything they do? That would be horrifying.
No. It adds so much time to it. Even when I want to photograph pieces I've made to put them online to sell them, you have to take so many pictures and edit it's a lot of work for sort of the return. You have to love what you do in order to even get involved with it.
Okay. So at some point, every new PCC client is going to get a tie-dye from Morgan.
You could. Remember, there was years ago when we switched from that not so great vendor to our situation with our current prescribing platform. And Paula said, "Hey, would you like to make like 80 tie-dye?" They were tie-dyed and screen printed. So now those are like contraband because they say the old, vendor on that.
The first vendor we had.
Yeah. So we still have a couple people that come to the conference every year, wear the tie-dyes with a lot of they're like front row in my class, waving. I love that.
I will say, if you work at PCC, you never have to buy a t-shirt again.
No, we have too many.
We have too many. All right. So, I understand that you wanted to play a game with me.
Oh, I do. I have to get my notes.
Everyone who knows me knows I don't prepare for anything in my life, including this, but I was told that Morgan wants to have some fun with me. This is where we're going to get to see if I have any brain cells.
No.
So,
this is
do we need any setup?
No. I wasn't sure if I could type them to you in the chat, but I'm going to say them out loud, especially for everyone that will listen later.
Okay.
So, I'm going to give you a list of 5 drugs and a small description of them, and you have to pick which one is not real. And they're all going to sound crazy.
Well, there'll be 5. 4 of them are real. 4 of them are real and 1 is not.
That's the premise, yes. So,
all right.
Are you ready?
I'm ready.
Okay, I'll type them to you if you need them later. So, I put these in alphabetical order. These are not in any other order besides the alphabet.
And are these the commercial name, or are they the generic name?
You are such a good student. So there is a mix between the brand name and the generic name, and so
okay, all right. No one has ever told me that I'm a good student, so
you are. You've already passed.
Still consuming this. Okay.
All right. So let's begin. First, I can't even say these without laughing. Okay, flurbiprofen. This is a non-steroidal anti-inflammatory drug for pain relief. So that's flurbiprofen. Now that might sound like Scott Kirby's nickname,
That's right.
scurvyprofen, but it's not. That's flurbiprofen. Okay.
There you
Next
go.
up is moxifloxacin. That is a fluoroquinolone antibiotic. You might enjoy it with a can of Moxie the soda.
All right.
Next up, lubiprostone. That's a medication to treat constipation. Just think that one through again. All right.
Yes, I know. I've got all of these. Every one of these has a word with a word root that makes you think something. Keep going.
Isn't it fun? Okay.
Yeah,
Next up is scalaxin. That's a skeletal muscle relaxant.
tough acting
Yep.
scalaxin. That's a real one. Keep going.
Okay. The last one on the list, we have reached number 5 is Skyrizi.
Oh, first of all, I've seen the ads for Skyrizi. I know that one. I'm going to say it's the Flurby one is the fake one.
No,
first
that one is real. Do you want to know the true answer, Chip?
Sure.
They're all real. They're all real. I tricked you.
So I couldn't win that game. I would have had to Captain Kirk it to win. All right.
I can't believe it though. Like lubiprostone. I mean, that one is like, who's naming these drugs? That could be if you wanted to know what I should have done with my life was naming drugs.
Name drugs. There's someone who got paid $250,000 to sit in a room and it's now all AI. Okay, that was that's interesting.
Well,
you know what you should do? You should do 2 rounds of that.
Oh.
And sneak a couple in, and you should insert the names of people at PCC into them. Because you made that joke about scurvy. And so you could have okay.
Chippyprofen. I mean, we could.
Chippyprofen. I mean, look, you've got a last name that could probably create a whole family of drugs.
It's true. There was
my name's too short.
Too short. Last year at the conference, we did those sort of introductory group sessions on Tuesday, and I printed out old handwritten prescriptions, like legitimate handwritten prescriptions that no one could read, and pictures of tablets and capsules, and said, can you actually name these? And they each had little forms that they could fill out. And there were so many comments that were like, I am so sorry that I've ever written a prescription that looks like this. And so really it was educational for everyone. And then I had to review all them and choose the winner. And you might remember this, but one of our doctors, Dr. Dobos from Connecticut, he won both rounds. Well, Dr. Dobos was a pharmacist before he became a doctor. So he
was cheating.
Let that be a list. So it was really fun.
Oh, yeah, I was not there for that. That sounds great. And it's amazing to me that people argue with the benefits of doing any of this digitally.
Mm-hmm. For sure. That was really the thank you for reminding me. That was really the point when everyone said, I can't believe the pharmacy staff has to read these. I said, no, that's why. Just use the software. Everything. There's still problems, but it's way easier than those scribbles.
PCC is literally speaking to 3 practices right now who are still on paper for everything. Wow. Who are looking for an EHR. We'll see if any of them become clients. And whenever you say to them, well, how do you read the charts? Like, look at the chart you just gave me. Well, I know what it says. And the point is, I'm like, but you're not who that chart is for. That's, what if you're not the one to read that chart? And also you're fibbing if you think that you can read your own charts.
Yeah.
Well, I know what I meant. And I'm like, it's
do it for the future version of you,
Right. Okay. All right. Morgan, anything else you'd like to add? I will add myself. Thank you. This is nice to get the insight from the people who are behind the scenes. But anything else you'd like to add or share with our crew?
You had warned me you wanted to talk about vaccines at pharmacies. Do you still want to do that? You would regret it.
Yeah. Here's my simple question.
Yeah.
What is I don't know the answer, though I can guess.
Yeah.
What do you feel, or what is your opinion of pharmacies giving vaccines to children?
Oh, let's start with giving them to adults because I feel better about that one, way better. But I still don't like it. How's that for an answer? Kids are
That's a
just
good
like, to
start.
me, it's like off the table. I still worked at Walgreens, so this must have been prior to 2010. This was new in New York State that that the pharmacist could administer vaccines. It was a whole thing. But remember, back then we didn't have COVID. So this was just flu vaccines, essentially. Nobody wanted to do it. I mean, it's like intriguing to learn how to do it, but to interrupt the flow that is already jammed up, you've filled prescriptions before, so imagine this is another one of those, you don't have to pick up the phone, I will, but the big corporations, they were driving it. It was absolutely Big Mama Walgreens was saying, you better, do as many flu vaccines as you could on top of keep up with your prescription volume. So the phone rings and I have to answer the phone. I say, thank you for calling Walgreens. This is Morgan. Would you like to schedule your flu vaccine? Imagine you got like an 80-year-old grandmother and she goes, what? And I have a loud voice. So I'm like, I know she heard me, but she's like, what do you mean? So then I repeat myself and they say, well, I just want to get my prescription refilled. It's like, I'll handle that too. But then I'm supposed to follow up again, and just say,
you're a salesperson.
Yeah, it turns out, right? So let's say people were excited about the sort of the ease of being able to do it. You didn't have to make an appointment, really. You could walk in anytime. But you're at that pharmacy counter and there's patients everywhere. They've dropped off their prescription. They're waiting. They haven't given you the paper yet. The phone's ringing. The drive-thru's going ding dong, ding dong. And then someone's ready and they're like, I'm here for my flu vaccine. There's not enough time in the day for all of these things to occur.
Right.
For the pediatric patients, that to me is like a no way. I mean, that doesn't even make sense to having the kids in there. And I'll tell you this story about this college kid because I can't even imagine that being applied to a tiny person. But it's the same thing. Imagine a day, the pharmacy, it's swamped, and this college kid is essentially skipping down the aisle to the pharmacy. He's overjoyed to be getting his flu vaccine. And I remember in this moment thinking, this kid's had a lot of Red Bull because that was like the caffeine of choice back then,
Right.
And he announces, I'm here for my flu vaccine, whatever. So we had a separate room that you would go to. It was a private room, but I'm still in the pharmacy, doing my thing. And I hear this incredible thud. I thought I'll remember it for the rest of my life. And then the pharmacist screaming, call 911. I'm now ready. I'm going to call them, but I don't know what's going on. So I have to open the door and this college kid is on the ground. Like he'd gotten the shot and just keeled over. And so it was a small town. So I knew the EMTs that were rolling in to take care of the whole thing. But it was in that moment, I realized we'd never been trained on the rest of the patient care. Experts at pharmacology, but administering the vaccine was as far as we got, and so to think about like kids and adverse reactions, just no. And the continuity of just the whole thing is just big gross. So
yeah, the impression I get is that pharmacies want to vaccinate, but pharmacists do not.
No.
Like if you had wanted to do that work, you would have gone into that work.
Right.
Right.
There's
I was on a state health department conference call a couple of years ago, and one of the people in the call was presenting about, it was for here in Vermont, presenting about how they wanted to expand the vaccines that you're allowed to give to children in Vermont. And I will say there is an argument to be made in places with pediatric deserts that I would rather have a kid get an MMR from a pharmacist than not at all. But that is okay. Those are not edge cases, but those are exceptions. Certainly, here in Chittenden County, it's not an issue. It's the opposite of an issue. But one of the questions that came up, and I think I'm the one who asked it. If not, I think I might have typed it. Someone asked this because I just can't remember if I were allowed to say anything. And they asked the guy representing the pharmacies, well, what about all the children with special healthcare needs? Or what about someone who has specific questions? Or what about someone with certain... And the pharmacy guy said, oh, the difficult ones, we'd send all those back to the pediatrician. And I'm like, oh my God, you just said the thing out loud that you're not supposed to say. He's like, oh, no, we only take the easy ones. And I'm like, oh, how, I mean, come on.
It comes back to my earlier comment. They're going to buy something.
Yes.
When they come in. They might even
When
switch
I
their prescription. You know,
yeah,
it's a thing.
when I got my COVID shot, so here in Vermont, most of the COVID got distributed to the pharmacies.
Mhm.
All right, not to the doctors right away. So I went to, I think it was Walgreens,
Yeah.
and I walk in, and two things happen. This will make you laugh. So it was such a line of people getting COVID shots that they had set up stations in the aisles. Okay. So it wasn't like you went into a little room. It was like literally, I'm in the shampoo aisle and there's like a little curtain and there's
Mhm.
like a 5-foot, chair and a desk and then a curtain and then a curtain. And so there are people left and right. And okay, it's a mild HIPAA thing, but this is we all know I'm not that worried about it. But I went in and I was wearing a shirt like this when I couldn't get up. So I'm in this little booth and I take my shirt off to get the vaccine. And all of a sudden the curtain swings wide open and this woman is there to meet her friend and bring her some flowers. She's like, "Hey, yes, Sarah." And I'm like, I'm in an exam and you just opened this. I'm like, got my shirt off in the middle of Walgreens. And then I was like, and they give me the shot and I said, "All right, so what?" I knew what the answer was.
Yeah.
I knew what I was asking, but I was like, "So what do you want me to do now?" "Oh, you need to stay in the store for 15 minutes. We got a bunch of stuff on sale. You'll love it." And I was like, "No, I will be going somewhere else."
I had I had a very similar experience. It was just like lined up and it was like one by, and finally I went in and I was like, "Oh, I remember these days." I was kind of telling him like the same anecdotes and you could just see the look at his face. Like, I'd much rather be filling prescriptions. In
Yeah.
that time period, there was a benefit to it. I think the ease of it, but like for kids, it's just
Kid's a
no,
different
no,
story.
thank you.
Yep.
Way different story.
Yep.
No.
And that kid goes home, has reaction at home. Who are they calling?
Yeah.
They calling back over to Walgreens? No,
No.
they're not.
No. There's no after hours line. We closed.
Right.
You know.
Yeah. And so that pediatrician's like, "You got a what? Where? How?"
I know.
Well, there we have it. Well, Morgan, thank you. I appreciate it. I didn't appreciate the fact that you tricked me and I had to guess one wrong answer no matter what. But it's okay for next time.
I hope
And
you'll.
I will. And let's have you back to share some more e-prescribing madness. Maybe I'll have you be Dewey's handler.
Yeah, I know. I think he would love to be on the show. You can have us all. So this was
All
a
right,
real
perfect.
treat. Thank you, Chip.
Right. Thank you.
Take care.
Bye-bye.
Thank you for listening. More information can be found in our show notes. Production and editing by Chip Hart, Ali Squires, and Chris Forleo. Music by Challenger C. I'm Mark Herney.